Hi, I'm Dr. Jeff Yu, a board-certified ER doctor in the USA and Canada, and today I'm going to be reviewing the Pitt Season 2, Episode 7. Let's get to it.
Great, we were diverted here. Is there a trauma room open?
Trauma 1.
What's the story? My buddy Officer Hero, high velocity GSW. He's getting harder to bag. Warehouse robbery gone sideways.
Okay, so he's got a gunshot wound through his neck. He's already been intubated and he's ventilated. I'm not sure what this police officer is, like if he's an actual medic that works for the SWAT team or what, but that's a little bit unrealistic for a police officer to be ventilating one of his comrades.
Road.
I miss seeing you in uniform.
You should see me as a flight attendant.
Oh shoot, he's one of the doctors. Crazy.
Do you do this intubation?
Under active fire, yeah.
Are you serious?
I go in with the team in case there's an injury.
That's badass.
Yeah, so there are some physicians that actually work with the police force and the SWAT team that actually attend active shooter cases, and they act as like a first responder and medic at the scene. So, you know, this is potentially realistic.
Dr. Santos, what could cause respiratory failure in an intubated patient?
There are a lot of
Dopes.
possibilities.
Think dope.
Displacement, obstruction, pneumothorax, equipment failure, good lung size.
Dope or dopes is a mnemonic that we use to think of all the different potential causes for respiratory failure in someone that's already intubated. She already mentioned the top four, but there's actually a fifth one, which is S, which is breath stacking, that often occurs in people with COPD or asthma, where you just ventilate them way too quick, and essentially their lungs get hyperinflated, and it compresses their heart and prevents more blood from filling.
Getting no pneumo.
It is
Jesus.
displacement. Okay, that is a transected trachea.
Oh,
Pulling
man.
out. Bag.
Damn. So I've seen this in real life when I was doing trauma surgery in South Africa with a transected trachea. We tried to intubate the patient from the mouth, but there was just too much blood that was kind of spilling out from the mouth. And so we actually just put the tube straight through the hole to actually ventilate the patient, and the patient survived.
But if you intubate again, won't it just come straight out the wound?
Yep, exactly. So we're gonna need another plan. Okay.
Yeah,
That's down to 83.
that looks very realistic.
Yeah, he's not moving in the air. Okay.
So typically what we would do if the patient already has a big open gaping wound to the neck that is bubbling, essentially we would treat that as an airway. We would use a 6.0 endotracheal tube and just put it straight through, inflate the balloon after it's a couple of centimeters deep and you can't see the balloon anymore, and just ventilate straight through there. This is 100% a survivable wound.
Lido with epi, it'll clamp off any little bleeders.
Some skin hooks. For Shiley.
I don't like the
Forced Shiley is a tracheostomy tube that you would put in. So they're kind of debating which type of tube to put in.
curve of a Shiley.
I didn't know you were so picky.
Santos, take a break. Help me cut down a 6.0 ET tube.
Oh
What
shit,
is
I called the
going on
6.0
here? You have a
ET
field
tube.
medic assisting you?
Dr. Abbott is an attending, and he's also a SWAT physician.
My buddy Hero here is in bad need of an airway. They cut it right here.
We can do this.
No, I got it.
Very retracted, but I think I can get it.
Both lungs are up. Sats standing the belly now.
Okay.
So what we would typically do is use a tracheal hook. It's a hook that comes in a kit, and because the field is usually very, very bloodied, you would use a hook to actually hook where you can feel cartilage to actually pull it up, and then either use the hook or just use your finger to feel where the trachea is, to feel kind of like the cartilaginous rings. And once it's in there, you would actually replace the hook or your finger with the 6.0 endotracheal tube to put it in place.
I got it.
Oh, jeez.
Gently, or we're gonna lose it.
Down to 89.
I'm in, balloon up.
End title, excellent waveform.
Good breath sounds.
Also the tracheal to the skin, 2.0 silk.
And while you were playing him with that airway, you missed a big bruise in the left upper quadrant.
He was wearing body armor.
High velocity projectile doesn't have to penetrate to do damage.
That's true.
There's no fluid in the suprasplenic space.
Let me look. Okay, right there.
Looks like a subcaps.
So I guess it's a little bit unrealistic that like they would have had a really good view, and then immediately afterwards someone else gets the same view and there is free fluid. Typically what we would do is we would tilt the bed in Trendelenburg position where their head is beneath the level of their feet, so that if there's any free fluid in the abdomen, all the fluid will track up towards the spleen and the liver, and then you would see it on the ultrasound. The other thing is we would do multiple fast exams to make sure that there's no blood in the abdomen. If this guy remained really unstable with low blood pressure and a high heart rate, he would be taken straight to surgery, and we would perform an exploratory laparotomy, and that's where we would make a midline incision from the sternum or the breastbone straight down to the pelvis to open up his abdomen like doors and see what's bleeding in there. And in a case like this, it would probably result in a complete splenectomy where we take out the spleen.
Hematoma of the spleen. Must have been a big impact.
AR-15 muzzle velocity is 3,000 feet per second.
CT angio of the neck ASAP, along with CT.
Yeah, CT angio of the neck is totally warranted in a case like this, because even though it took out a chunk of this guy's neck, with gunshot wounds, we often really worry about temporary cavities, which is essentially a shockwave injury to all of the surrounding tissues that the bullet didn't even touch. So you would be really concerned that it might have damaged the carotid artery and the external jugular veins, which could cause, dissections and a subsequent stroke or bleeding with expanding hematoma to the neck.
Hey, you're gonna be okay, hero. We're getting you to surgery. All right.
Typically what we would do is give the person like sedatives like ketamine or propofol, so that once we've secured their airway, so that they're not, totally aware of what's going on, because I would imagine that the guy's in really, really bad pain from both the neck wound and his intra-abdominal injuries. So for them to keep this guy completely awake and conscious is, I think, a little bit unrealistic, especially for someone that has a new tracheostomy. She's impressed.
Really?
She likes what she sees.
You spend time in the Middle East?
More than I would have liked. She seems cool.
Yep, maybe. More Westbridge cases arriving every moment. She would be more comfortable at home.
The debrief is lovely.
Yeah, doing a proper debrief for a team that's gone through something very traumatic or heartbreaking is a very fine skill that is very difficult to teach through medical school or residency. But when you see someone who's actually very skilled at it, you know that they have both the empathy and the sensitivity to actually help guide other people through it. What that would entail is creating a safe space for everyone to chime in with their own emotions and to help guide them through this process where they feel like they have somewhat of a sense of closure after this person has passed away.
Need the room. Find another place to lay your head.
Not even a 20-minute power nap? And my double's at 1:30.
No, we're getting Westbridge diversions, and chairs is insane. Didn't you see out there?
Ew, I did not come in through that mess.
Okay.
This is actually realistic. So oftentimes, especially on overnight shifts, sometimes the resident doctors and the nurses that are on shift will actually find some of the empty beds or spaces to lay their head down for a short period of time to get a power nap and then go back to work.
Yeah.
People sleep in here?
Yeah, night shift doctors need rest, especially if they have to come in during the day. But today we can't waste the space.
Headache and abdominal pain?
So these video translators are the exact same ones that I use in my emergency department. I guess my biggest question is, like, if they had this available to them, why didn't they bring this out like 2 hours or 2 episodes earlier? Because this patient's been waiting that entire time.
God, come on, you piece of shit. Fuck.
She's swearing in front of the patient. That's funny. She actually cracks me up as a character. I don't know why so many people don't like her character.
I'll be right back. Sorry.
Yeah, that's a big no-no on Santos's part. Like, if the patient has concerns about doing a test and isn't exactly sure as to why a test is being performed, it is her duty as the doctor to explain both the risks and the benefits and what specific question they're trying to answer by doing this test. Because a CT scan is not without its own risks. Like the amount of radiation that you're exposing to your body, there is a potential that other cancers could be developed because of that radiation, say like 10, 20, 30 years down the line.
Son was brought in extremely agitated.
You'd be too if you were tased.
And why the fuck do they do that? This is bullshit. We're taking him home.
Why don't we step out for a second? All of his tests look good, but Jackson has reported hearing voices.
Yeah, it can be incredibly stressful for a family to hear that one of their loved ones, especially their son, has a psychiatric illness or some kind of psychotic break. I've had this kind of scenario before where the family does not think that the patient needs to be involuntarily admitted for psychiatric reasons, and they're essentially in complete denial.
What happens next?
We keep your son here for the next 3 days for observation and therapy.
Yeah, I typically don't tell family members a strict timeline of how long the person's going to be admitted to hospital because I just think it sets them up with false expectations. Typically, the way that I frame it is, he's going to be staying here for at least 1 or 2 days for therapy and observation, and after that, we would just take it day by day. If he does really well and improves very quickly, then we would have a conversation about discharging him home with outpatient therapy, but sometimes it often means that they stay for a much longer period of time.
Look, I know this must be so scary for you. And you probably feel betrayed by your parents. But they had no way of knowing about Jackson. And some families just have a difficult time talking about mental health.
Yeah, that's a really good point. I think that one of the best things that have come in the post-COVID era is people are way more open about talking about their mental wellness compared to pre-COVID. I think that mental illness really does need to be destigmatized, and we need to be way more open about talking, about our feelings and how we're coping with the circumstances of life, because life is very hard for everyone.
I have a sexual assault victim in triage. I called PAR, so an advocate is on the way.
Okay, we'll take care of it.
So whenever someone who's suffered from the sexual assault comes to the ER, typically what happens is myself as the ER physician will assess them to make sure that there's no major traumatic injuries. And then once they're technically medically cleared, then I would consult the sexual assault team or the SA team to come and assess them. Typically what that involves is a more detailed history into how the sexual assault happened, and also a very standardized pelvic examination where they can actually take samples, which would later be used in court hearings. The SA doctor would document everything in a way that would be essentially used in court later time if the SA victim decided to press charges against the assaulter.
You can call for a sane.
On a holiday? It'd be ours. We're not going to make this patient wait, and since I'm the only sane on staff...
Princess will cover.
Yeah, that is a good point. We try not to make our SA patients wait for long periods of time. It's not that they would be triaged at a higher priority, but typically if they pop up onto the triage list or the whiteboard for patients that are waiting to be seen, we would kind of handpick these patients out of the waiting room to see them in a quicker manner so that, this traumatized person is not sitting in the middle of the waiting room with a bunch of other people who are there for other medical reasons.
We do forensic exams, collect evidence, and hand it over to the police if a report is made. We also provide resources, support, sometimes even testimony.
You go to court?
Yeah, this is actually very accurate.
Things are very valuable in a hospital, especially in ED. More nurses should train for it. Hi, Miss Miller. I'm Dana. How are you doing?
I think actually every single one of the sexual assault doctors in my city is a female physician, and that is on purpose. I think that if you have a male physician come in after a woman was just sexually assaulted by another male, that can also be a little bit intimidating and traumatizing for the patient. So this is just one area where the care is a bit gendered as well.
Right, this can be a lot. You up for it?
Yeah. Yes. I'm good.
All right, let me know if you need to step out.
Yeah, I think this is a really good point. Hearing the stories of sexual assault and kind of putting yourself in the shoes of the patient as they endured such a traumatic event can be really, really jarring. So I think that is really good that Dana is checking in with her student to see if she's actually up for this and has the capacity to hear this kind of story and deal with this patient encounter.
Once I open this kit, I cannot leave the room. But if you need a break or some air.
So the reason why Dana would not be able to leave the room once she opens the sexual assault evidence collection kit is because of something called chain of evidence, and that's a very strict and controlled record of everyone who has handled a sexual assault sample from the time that it's been collected all the way to the courtroom, and that allows the sample to be essentially to have strong integrity in the eyes of the court.
We'll get you new clothes. Don't worry.
All right.
Emma's gonna be behind this curtain, and I'll be in here with you. And take off your shoes first.
This is incredibly realistic, and for anyone who's watching who has had to go through something like this, I know that this can be quite triggering, so I'm really sorry that you've gone through this.
Some on the left wrist. Swab.
So I've never actually been involved in an actual forensic sexual assault examination. I think for obvious reasons, like they typically wouldn't allow learners to kind of sit on this type of exam. And I think also they typically don't let men into the room for a woman who's just been traumatized. So, I can't really comment whether this is accurate or not with the blue light, but if you have any experience with this, let us know in the comments.
Hello. I'm sorry to meet you under these circumstances, but I and my organization are here to help you navigate everything that comes next. I brought you some clothes and basic necessities. I can even stay with you through the rest of your examination if you'd like.
It's really great that they have organizations like this. I know that we have social workers specifically that are trained to deal with sexual assault survivors in my city. So, I think it's just really nice to have someone that's able to kind of hold their hand through this entire process, because it can be very, very stressful as a survivor to go through a medical examination as well, especially being placed in the stirrups. That in itself is a very vulnerable position to be in, even if you haven't been a victim of sexual assault, but to have it directly after the sexual assault can be very, very difficult for a patient.
I don't want to do this anymore.
Tell me why you want to stop.
He's my friend.
He's not your friend.
He knows all my friends. It was just a dumb... He was drunk. He didn't mean...
Yeah, I think, this is something that we see with sexual assault. If you're the victim, there's a tornado of different emotions and thoughts that are going through your mind. Sometimes people can feel guilty for reporting the perpetrator. You should not ever feel guilty for reporting this if this happens to you. And you shouldn't, justify the person's actions for whatever reason. If you have been the victim of sexual assault, you should feel justified and morally and ethically justified reporting that. That is absolutely your right.
Why don't you take a breather and come back, and whatever you want to do, we'll do.
Man, this episode is very, very heavy. Crazy. Oh my God.
Okay, do you have any fever, vomiting, diarrhea?
No, it's just a stomachache. But I'm still having ice cream tonight.
We'll just see how you feel later.
This is one of the things of being a healthcare practitioner is all of your friends and family will call you whenever they have an issue. Some people really, really do not like giving medical advice to people that they know. I'm kind of the opinion that one of the greatest gifts of being a physician has been able to help the people that I care most about. So, anytime that I have a friend, family, or an acquaintance reach out to me, I'm always more than happy to help out. Uh-oh, what's up with her?
You have reached the Pittsburgh Neuroscience Group. It's 2. To leave a message for the doctor.
I hate those answering machines. So annoying.
Hi, this is Dr. Baran Al-Hashimi. I'm a patient of Dr. Fairgraves. I need to speak to him if he's on call. Call me if he has a cancellation. Thank you.
Wow. So I wonder what kind of condition she has that she's being seen by a neurologist. Whenever we get our licenses renewed, we always have to, say to the medical board whether we have any medical or psychiatric conditions that would, potentially limit or impair our ability to think rationally and treat patients. So, I wonder if this will be introduced as something that impairs Dr. Al-Hashimi's judgment.
It's gonna be really noisy here and you won't get any rest. At home, you'll be surrounded by your family and be more comfortable.
It's your choice, Roxy.
Yeah, I think I mentioned in my last video that medical beds are a scarce resource that we really do need to protect, especially in a crisis where you're on ambulance diversion and patients from other jurisdictions or hospitals are actually being transferred to yours. So in this scenario where this patient has acute pain that could technically be managed at home with increasing doses of opiates, I would also do the same thing in trying to convince this patient to go home, because again, if you allow this patient to stay here just for analgesia or pain control, that means that they're going to be occupying a single private room where other critically ill patients could possibly be managed.
I don't want you living with my ghost.
I will happily live with your ghost.
Can we just all stop talking about ghosts, please?
Yes, I'm sorry.
That can be so traumatizing for a child, especially if someone is, talking about their own mortality and dying. I just can't even imagine what it'd be like to have, to be a child with a terminally ill parent. That would be so tough to grapple with all those things at such a young age.
Elliot Green, 17, syncopal episode of football practice.
Look, I just got dizzy, okay? It's hell week. I need to get back.
Yeah, okay, tough guy. Does syncope at football practice.
I just needed to hydrate.
Possible heat stroke? Well, with heat stroke, you would have an altered mental status.
Differential for syncope in an adolescent.
Cardiac arrhythmia from drugs. Long QT, WPW,
sepsis.
or Brugada.
Brugada is more common in Asian males.
But still should be considered.
Long odds, sir. Brugada prevalence is 1 in 20,000 in North America, as high as 1 in 300 in Asia and the Middle East.
And?
First described in 1992, has a high incidence of sudden.
Yeah, I think it's a little bit unrealistic that these medical students know so much about Brugada syndrome. In my previous experience teaching medical students that rotate through my hospitals, most of them haven't even heard of Brugada syndrome. It's a pretty rare sodium channelopathy that can cause life-threatening heart irregularities. And I think most 3rd and 4th year medical students have never really heard about it unless they're like a strong emergency medicine keener and they've done their reading. So for both these students to be able to rhyme off everything about Brugada syndrome, including the history and when it was described, is actually very unrealistic.
Did you just say sudden death?
Temp is 102.5.
Sorry, our student...
So his temperature is 102.5, which is elevated. This is consistent with hyperthermia. Typically, when we think about heat exhaustion versus heat stroke, there's 3 differentiating features. One is the temperature. So typically, someone with heat stroke will have a really high temperature above 40.5 degrees Celsius. They would also have altered mental status, like a seizure, coma, or delirium. And they would have signs on their blood work of a really bad liver injury, typically in the multiple thousands of their liver enzymes, whereas heat exhaustion, they typically don't have any significant liver injury.
Other than standard labs, what else to order?
CK probably. What else?
CK,
Troponin.
to rule out rhabdo.
Yeah.
To make sure you don't have any muscle breakdown from the heat.
Cooling room for Elliot here in the other heat exhaustions we will inevitably get today.
Yeah, so for heat exhaustion and heat stroke, the initial management would be quite similar. So in most ERs, what we would do is we would spray them down with mist and then use a fan to actually blow them down. That's kind of the quickest and the easiest way to cool someone down very, very rapidly. Another thing that we commonly do is we get ice packs and put it in the axilla, the armpits, and the groin. In severe hyperthermia for someone that might have like a toxicologic cause, and these things like cooled IV fluids, ice packs, and misting with fans aren't working. Sometimes we would actually consider more aggressive measures like using a Foley catheter in their bladder to actually flush cool fluids. And sometimes we would even consider doing something like ECMO or hemodialysis, but I think that would be incredibly rare.
Daniel Scott, 32, weekend dizzy while washing his car, tachy at 106, BP 90/60, temps too high to register.
We have a cooling room set up in North 5.
Okay, how you feeling, Mr. Scott? That is a heat stroke until proven
Let's
otherwise.
see if we can't fix that. He's going to need a core temp, a CMP.
Whoa,
oh,
hey,
he just
we need
seized.
a trauma room. What's open? 2.
I'll grab the Ep7.
Any past medical history?
No, wife says he's healthy. No meds, no allergies.
He needs a core temp.
So a core temperature would be done in one of 3 places. One is the rectum, one is the bladder, and the other is if you have them intubated, you would push the temperature probe down and it sits in their esophagus. This guy looks like he's in heat stroke. He's got dry lips. He has a temperature that's too high to read. And so the immediate management would be to give the patient a big dose of benzodiazepines like Ativan or midazolam to stop the seizure, because the seizing and the muscle activation from a seizure will actually drive the temperature even higher. So you want to abort that seizure immediately as quickly as possible, and then you would cool them down very, very aggressively with everything that I mentioned earlier.
Orders? Second IV was saline open, sepsis panel, UA, urine drug screen, EKG, and CK.
I don't see any apparent trauma.
So Santos made a good point. She's doing a sepsis panel, including blood cultures, because even though there are, there's a heat wave in Pittsburgh right now, sepsis or a severe life-threatening infection would also be in the differential diagnosis for causing this person's presentation. So that's something that you would not want to miss. You wouldn't want to anchor on the diagnosis of heat stroke if this guy has a bacterial illness and the correct management is actually antibiotics.
Rectal temp is 104.6.
Okay, let's start with 4 ice.
104.6 is very, very high. Anything over a temperature of 104 Fahrenheit would have the potential of denaturing the proteins within your body, especially your brain, and this can actually cook your organs. So you would want to rapidly cool this patient.
Packs on the groin and axilla. Should we do a full body ice bath?
That'll take too long. You have an Arctic Sun?
Yeah, we do.
Get pads on the chest, abdomen, and both legs. I'll check.
So Arctic Sun is essentially, it's a machine that has pads that have water that runs through these pads and cools the patient down. We often use this for something called targeted temperature management after someone has had a cardiac arrest. They also mentioned doing a full ice bath. Some hospitals I know do have ice baths where they can actually dunk a patient in and keep essentially everything beneath their neck completely submerged in these ice baths during a heat wave. That's not something that my hospital has, but definitely would be a very effective way to cool someone down very rapidly.
Where are you going?
Home. You take these out?
No. It takes 48 hours for you to get out of DKA. Your blood is still full of acid.
Look, I can't add thousands of dollars to the $100 grand I already owe.
I'm sorry, 100 grand?
It's a medical debt.
Yeah, I think the American healthcare system is just so grim. I recently did a podcast with 2 of my American colleagues who left the USA and started practicing emergency medicine in Canada for multiple different reasons, but one of the biggest reasons was all the daily ethical dilemmas that they had to deal with patients who were underinsured, didn't have money to pay out of pocket, undocumented immigrants. It just makes an incredibly difficult job almost impossible.
Diaz, I know it's not ideal, but can you stay for at least 12 hours? It will get you out of the danger zone.
No.
So she's doing a really good job trying to advocate for the patient and convince him to stay. If I were that physician and this guy decided to leave, I just don't know how I would sleep at night. Like knowing that this guy's probably going to get more and more sick and possibly die for something that's completely preventable as well. That would just eat away at your conscience.
It's a boating accident, swimmer versus propeller.
Ouch. What body parts involved?
They didn't say.
How old?
Nope.
Anything?
All I got was boating accident, swimmer versus propeller.
Propeller. Got it.
Damn, dude. That's going to be a bad trauma, I'm sure. When you get a pre-notification that you have a bad trauma like that coming in, what we would do is we would assemble our trauma team in the trauma bay, bring a level 1 transfuser, which is like a rapid blood transfuser, and have all of our equipment ready with chest tube trays at both sides, because you just have no idea what kind of injuries the victim is going to have. So you want to have everyone assembled, do a quick pre-brief with the team, so that as soon as the patient arrives and is on your bed, you can just go off to the races and have everything done very quickly.
He's good. Better, he's coping. Gonna be a senior this fall.
It's not very typical for doctors to actually stand on the helipad while the helicopter is landing and to receive the patient.
For all of us to go through. Yeah. Okay, I'm just gonna say it. I'm sorry. I betrayed your trust. I betrayed our patient's trust. And I'm really fucking sorry. It'll never happen again, I swear. I'm really glad that you got the help that you need. But I don't know if I want you working in my ER.
Ouch. Ouch.
Okay. 1, 2, 3. Watch that buckle.
You need me in here?
Nope. We have a senior resident and an attending.
Mel, can we start with a...
fast, sure.
Yes, please.
Why?
Man, so he was just given a big emotional blow, and for him to be leading this trauma, I just can't even imagine. Because like when you're leading a team, you have to be completely focused on the patient that's lying on the bed. So for him to be leading this case after Dr. Robbie, someone that he really looks up to and is attending, saying that he doesn't want him on his team working in his ER, that's just, I feel like if I was in Langdon's shoes, my head would just be spinning and ruminating about that. So I don't think it's right that he's leading this trauma.
Okay, let's have Oneg ready, but don't give it just yet.
Anything else?
How about a hemo-Q?
He's second guessing himself now.
Yeah, of course.
Ceftazidime is up, and first hemoglobin 8.2.
8's pretty low. He must have bled down from 14.
Anything you want to do about it?
Yeah, hemoglobin of 8.2 is really, really low. And in the setting of trauma, especially in a young, healthy patient, we would be really concerned that the patient is bleeding out. So we would typically start a massive transfusion protocol at that point and do serial blood tests or hemoglobins to see if the hemoglobin continues to trend downwards. But if someone is very hemodynamically unstable, yeah, you would just be drilling them with blood products.
What else do we know?
Intubated in the field due to poor tidal volume. EFAST was negative for pneumothorax, so no need to do a chest tube. And no free fluid in the abdomen. Good hemostasis inside the wounds, nothing arterial.
So I think what they're showing here is just how much Langdon's confidence has been shot from that conversation that he had on the helipad with Dr. Robbie. I think it's really great that they included this into the show because I think it just goes to show that leading a resuscitation and leading a team is much more than just book knowledge. You do have to have the confidence and kind of like the authority to guide your team and call the shots in that moment. If something like a critical discussion like that where Dr. Robbie tells him that he doesn't want him working in his ER, I think that would really impair your judgment and your confidence to be able to lead a resuscitation.
At first he had a hemoglobin of 8.2.
We'll follow that closely. With no active bleeding, I wouldn't transfuse just yet.
Oh, weird. I would totally transfuse this patient. I think most doctors would transfuse someone that comes in with traumatic injuries from a propeller to their chest wall and a hemoglobin of 8.2.
How's everything at home with you and Whitaker?
I don't see him all that much. He spends a lot of time at Amy's.
He got really close to the family when the husband was dying. He really believed that the guy would pull through. He helped her through the loss of
her husband, and then again when she had the kid, and now he spends almost every weekend at the farm.
That's crazy. If I was the attending and I heard that one of my first year residents was doing that with the widow of one of the deceased patients, I would definitely have a sit-down conversation with the resident, and I would 100% alert the program director, just to make sure that, you know, he's not overstepping ethical boundaries.
I've been trying to get to the bathroom for over an hour now.
Yeah, you and me both, sister.
She's cutting wounds to her legs. This is something that we see in people with borderline personality disorder. You know, I think a common misconception with cutting to the arms and the legs is people think that it's because they're trying to kill themselves. It's not necessarily because they're actually suicidal, but oftentimes people with borderline personality disorder cut themselves to kind of distract from the emotional distress that they're experiencing from their life. So I wonder if they showed the scars on her legs to introduce some kind of borderline personality disorder in Santos.
Hey, everybody, can you gather around, listen up for a moment, please?
Huh. I wonder what's going on.
And have your attention, everyone. The internal disaster at Westbridge has been identified as a cyber attack.
Oh, a cyber attack, yeah.
And now Good Dominion Hospital has been hit as well. IT believes we're still vulnerable. So we're going to preemptively shut down all the computer systems.
Oh, man. Jeez. So I worked during this CloudStrike outage when all the computer systems went down across, I think it was around the world or possibly just North America, but I was working on that shift and it felt like we were flying blind. It was probably one of the most stressful shifts of my career. And it made me realize how incredibly dependent we are on computer systems to do our job of modern medicine. So I feel like things are going to ramp up in terms of stress moving forward, given that they're shutting down the computer systems. I'm kind of scared because I feel like I'm going to experience a lot of PTSD from this.
Okay, hey, somebody get a picture of the board. Quickly, quickly. We're about to go analog.
Oh, dude. Dude, I'm getting PTSD, man.
Phones work?
Did you get the photo?
Yeah, I got it.
Jeez.
This is gonna be fun.
Okay, so that's it for season 2, episode 7. That was such a heavy, I was about to say shift. That was such a heavy episode. So many really heavy themes with the sexual assault, the patient with cancer who doesn't want to go home. I feel like this episode was kind of a setup for some of the more dramatic story arcs that they're going to introduce once the computer systems are completely out of service and they're having to go back to archaic medicine with no access to laboratory investigations, chest x-rays, CT scan results, or anything like that. I'm excited, but I'm also very nervous, and I feel like it's bringing back a lot of memories to when I was working during the CloudStrike outage, because that was honestly just a brutal, brutal shift for me. If you found this educational, entertaining, or helpful, please give this video a like and subscribe to the channel, and I'll see you in the next one.